All right, so I had someone from a student organization reach out to me from a university, and they wanted me to give a contraceptive lecture. So I decided to share it to TikTok since it took so long to do. It's going to be about an hour-long lecture, and it's going to be cut up into like, I don't know, 6, 7, 8 parts on TikTok. But this is my trial run, like my rough draft. All right, access to contraceptive care, pharmacists prescribing abortion laws post-Dobbs v. Jackson, and the therapeutics of hormonal contraceptive agents. These are my learning objectives. All right, pharmacist prescribing. Pharmacists are able to prescribe hormonal contraceptives in 34 states and Washington, D.C., of course, including Indiana. This was just passed last year. So the bill that was passed last year was originally called House Bill 1568. An important part of this bill is that it was written in that we get reimbursed for services with regard to contraceptive prescribing for our Medicaid patients. So the bill passed into law last year in May of 2023. It's now Indiana Code 2526, 25, 1 through 9. It allows pharmacists to prescribe like the contraceptive patch and self-administered contraceptives to patients greater than 18 years of age. It also does not allow us to prescribe abortion medications. So technically the emergency contraceptive Ella or ulipristal is an abortifacient technically in high doses. So we can't prescribe Ella. But we can prescribe Plan B. So if we prescribe abortion meds, this is considered a level 5 felony. So we can get our license revoked, and then we can possibly go to prison for up to 6 years or pay a fine of up to $10,000. There's no appointment necessary for pharmacists to prescribe. And then also what was added into this law was technically what we call a conscience clause. So pharmacists are not required to prescribe or dispense if the medication is contraindicated or against ethical, moral, or religious grounds. This involves technicians and interns too. So a conscience clause is denying based off of personal beliefs and values. Indiana is one of the few states that allows pharmacists now to refuse contraceptive prescriptions. It's also important to note that the Depo-Provera injection is technically a self-administered birth control. So pharmacists can prescribe contraceptives under what we call a standing order, which is when we have a protocol physician that we're billing under. In order to do this, we have to complete a board-approved training and then also complete a risk and a blood pressure assessment for patients every 6 months. We have to use USMEC to guide the assessment too. I'm going to go into that in later slides, but we can't prescribe contraceptives if they're category 3 or 4, which is when the risks don't outweigh the benefits of these contraceptives. It's important to know if systolic blood pressure is greater than 140 or diastolic is greater than 90, we can't prescribe an estrogenic contraceptive or a combined hormonal contraceptive agent. We have to go with progestin-only options. We may not issue a prescription to a patient after 12 months if they haven't been seen by a physician, PA, or NP, and then the limit per prescription is 6 months. We also have to provide a written record and document the screening and prescription record. And for medical records, they have to be kept for 7 years. Pharmacists also have to provide counseling to the patient about the therapy and inform them to follow up with their primary care provider or women's health provider. If for some reason there's a contraindication to the contraceptive methods or we can't prescribe it for the patient, we should be telling them why we can't prescribe it for them and then also provide a referral. You could do the required board-approved training on birthcontrolpharmacist.com. Here's the link to the standing orders for Indiana. You can also see the standing orders for like naloxone, tobacco cessation, immunizations, and EpiPens. If you click that link, there's a bunch of different resources for you, like an algorithm for prescribing contraceptives, as well as examples for a screening checklist based off of the type of contraceptive agent. Here's another example for a patient screening sheet. The CDC published the USMEC, or the U.S. Medical Eligibility Criteria for Contraceptive Usage, which provides recommendations on the safe use of contraceptive methods for patients of reproductive potential with various medical conditions and other characteristics. Category 1 is no restriction, Category 2 is benefits outweigh risk, Category 3 is risks outweigh benefits, and Category 4 are unacceptable health risks. This is page 1, but it gives recommendations of which contraceptives you should and shouldn't use in patients with like breast cancer, diabetes, cirrhosis, migraines with aura, like history of a blood clot. Page 2 has some more recommendations like with patients with hypertension, smoking, breastfeeding, SLE, and then also in the bottom right goes over some drug interactions. The CDC also has an app that assists practitioners in the selection of contraceptive agents and then also helps rule out certain therapies in patients with specific medical conditions and certain characteristics. Before prescribing contraceptive agents, we have to be sure that the patient is not pregnant. If we can't rule this out, then we have to refer the patient. So how to be reasonably certain that a patient is not pregnant? if no signs and symptoms of pregnancy and meets any one of the following criteria. The patient is less than or equal to 7 days after the start of normal menses, has not had intercourse since the start of last normal menses, has been correctly and consistently using a reliable method of contraception, is less than or equal to 7 days after a spontaneous or induced abortion, is within 4 weeks postpartum, or is fully or nearly fully breastfeeding, exclusively breastfeeding or the vast majority, which is greater than or equal to 85% of feeds or breastfeeds, amenorrheic, and less than 6 months postpartum. So amenorrheic means the patient is not menstruating. So some standing order extras is that the standing order for contraceptive prescribing is under Dr. Lindsay Weaver right now, but it will transition into using your personal NPI. NPI stands for National Provider Identifier. You have to go to the NPPES website in order to apply for an NPI. Also important to note that you can prescribe contraceptive agents for non-contraceptive usage, like for endometriosis, PCOS, amenorrhea, menorrhagia or heavy bleeding, PMDD or hormonal acne. PMDD stands for premenstrual dysphoric disorder. Another thing I'll add is that pharmacies or pharmacists may charge for services. Again, they cannot require an appointment for said services. So about 50% of pregnancies in Indiana are unintended. This is not a good thing for a state that outlawed abortion. So 35.7% of pregnancies in the US are unintended. This statistic was from 2019. So this went down from 45% in 2011. It's important to note that unintended pregnancies were highest among people who had low income, had not completed high school, or are non-Hispanic, Black, or African American. Abortion is nearly completely banned in 14 states. Indiana is one of them. Roe v. Wade was overturned in June of 2022, which is around 50 years after abortion was considered a constitutionally protected right. All 6 conservative judges on the Supreme Court voted to overturn it. I'm going to go over some important abortion laws in Indiana. First, we have Indiana Code 1634-14. In this law, it states that pharmacists are not required to dispense abortion-inducing drugs, provide advice or counsel pregnant patients concerning abortions, if that pharmacist objects to such procedures on ethical, moral, or religious grounds. It also says that other providers are not required to participate in abortions if they also object. Indiana Code 1618-1.6 defines what an abortion-inducing drug is. An abortion-inducing drug means a medication, drug, or substance prescribed or dispensed with the intent of terminating a clinically diagnosable pregnancy with the knowledge that the termination will, with reasonable likelihood, cause the death of the fetus. The term includes off-label use of a drug known to have abortion-inducing properties if the drug is prescribed with the intent of causing an abortion. Indiana Code 1634-21 requires an in-office dispensal by a physician with monitored consumption of an abortion-inducing drug. The drug may not be dispensed, prescribed, or administered after 8 weeks. Also included is that telehealth and telemedicine may not be used to provide any abortion. Also included in Indiana Code 1634-21 is abortion exceptions. Abortion is allowed in less than 20 weeks in order to prevent any serious health risk to the pregnant patient or to save the pregnant patient's life. Also included is if the fetus has been diagnosed with a lethal fetal anomaly. Abortion is also allowed in less than 10 weeks if the pregnancy is a result of rape or incest. I've included the full text for anyone who's interested. Also important to note that the medication misoprostol that's used for abortions is also used with other indications. So we're still going to see this medication outpatient. Indiana Code 1618-21 define what an abortion is. Abortion means the termination of human pregnancy with an intention other than to produce a live birth or to remove a dead fetus. The term includes abortions by surgical procedures and by abortion-inducing drugs. Misoprostol can be used for early pregnancy loss, which is what we sometimes call spontaneous abortion or miscarriage. It's also sometimes used for IUD placement because it dilates the cervix, which can allow for easier insertion. It can be also used for NSAID or stress-induced ulcer prophylaxis, as well as induction of labor and postpartum hemorrhage. Alright, this is part 2 of my comprehensive hormonal contraceptive PowerPoint that I made. I'm going to mention the website plancpills.org. This helps patients access abortion-related healthcare. Important to note that the website themselves do not sell abortion pills. They offer financial and emotional support as well as legal consult. They have a bunch of FAQ questions, and then they also give instructions on abortion pill usage. Here's some examples of some fact sheets that they have on their website of how to take abortion medications. I have both the misoprostol and the mifepristone and misoprostol regimen. Important to note that the mifepristone and the misoprostol regimen has better efficacy over the misoprostol alone regimen. Alright, so the types of different contraceptives. First, we have intrauterine contraception, which is an IUD. This can either be a progestin IUD, which is levonorgestrel, or a copper IUD. For hormonal methods, we have an implant, an injection, oral contraceptives, which come as either an estrogen and a progestin, or a progestin only. We have patches and rings as well. And for emergency contraceptive, you can use the copper IUD, Plan B, or Ella. In this PowerPoint, I'm not going to go over barrier methods like the diaphragm or cervical cap, sponge, condoms, spermicides, fertility awareness-based methods, or even permanent methods like tubal ligation or vasectomy, which are types of sterilization methods. So efficacy of birth control methods. The most effective is actually the next one on implant. It has a pregnancy rate of 0.05%. Next, we have sterilization, which has a pregnancy rate of 0.15 to 0.5%. And then after that, we have an IUD, which is 0.2 to 0.8%. The least effective methods are the barrier methods, which range from 12 to 24% with pregnancy rates, withdrawal, which is 22%, fertility awareness-based methods, which is 24%, and then spermicide, which is 28%. Important to note that these percentages are with typical usage. Up there, we see the pill has a 9% pregnancy rate. It's important to note that the pill is about 99% effective when used correctly. Before I go into hormonal contraceptive options, I'm going to talk a little bit about a non-hormonal method, Phexi. This was FDA approved in 2020. Phexi is a gel that lowers the pH in the vagina and makes it hard for sperm to move. Important to note that this is not a spermicide. When used correctly, it is 93% effective. In reality, it's about 86% effective. It's inserted into the vagina 1 hour before vaginal intercourse. You need an additional dose if greater than 1 act of intercourse within the hour. You can use this with condoms, and there are no contraindications. The most common side effects are burning sensation of the vulva, and then also pruritus or itching of the vulva. Some other side effects are UTI, vulvovaginal candidiasis, which is a yeast infection, vulvovaginal discomfort, BV, which is bacterial vaginosis, vaginal discharge, and then also dysuria, which is pain, discomfort, or burning when urinating. So USMEC Category 4 contraindications to combined hormonal contraceptives. 4 means unacceptable health risk. Method should not be used. We have current breast cancer, less than 21 days postpartum, acute or history of DVT, PE, or stroke, major surgery with prolonged immobilization, migraines with aura, blood pressure systolic greater than or equal to 160 or diastolic greater than or equal to 100, acute or history of ischemic heart disease, smoking when you're greater than or equal to 35 years old, greater than or equal to 15 cigarettes a day. Less than 15 cigarettes a day is category 3, so pharmacists still can't prescribe this. If a patient is less than 35 years old, this is a category 2, so it's technically not contraindicated, but I would still document it. Known thrombogenic mutations, vascular disease, peripartum cardiomyopathy less than 6 months, or with moderately or severely impaired cardiac function, liver tumors, either hepatocellular adenoma or malignant, severe decompensated cirrhosis, solid organ transplant that's complicated, SLE, aka systemic lupus erythematosus with positive or unknown antiphospholipid antibodies, and then also valvular heart disease that's complicated. There's a 3 to 5-fold increased relative risk of VTE reported in combined oral contraceptive users. So VTE is venous thromboembolism, aka blood clot. There is no or minimal risk of VTE associated with progestin-only contraceptives. High doses of progestins can increase risk for VTE. Important to note that the risk of VTE and blood clots is a lot higher in pregnancy and postpartum than it is with combined hormonal contraceptives. So estrogen-containing contraceptives or combined hormonal contraceptives. These come as oral contraceptives, a patch, and then also a vaginal ring. Mechanism of action of combined hormonal contraceptives. They prevent fertilization mainly by inhibiting ovulation via negative feedback. They also cause thickening of cervical mucus, which decreases sperm penetration. Combined hormonal contraceptives can also thin the endometrial lining, which can decrease implantation. Benefits of combined hormonal contraceptives. Of course, we have reduced unintended pregnancy and abortion rate. They can also decrease bleeding and pain with menstrual periods and also decrease the risk of endometrial, ovarian, and colorectal cancer. Important to note that there is a slight increased risk of breast cancer with combined hormonal contraceptives. The maternal mortality rate in the US in 2015 was about 2 times the risk of developing invasive breast cancer. So combined oral contraceptives. If you initiate them greater than 5 days after your period, you need backup contraception for 7 days. So backup contraception is another form of birth control like a condom. COCs are about 99% effective when used correctly. Important to note that you need backup contraception for 7 days after 2 missed pills. Let's get into the different types of combined oral contraceptives. First, we have monophasic. This means that there's the same amount of hormones in each pill. These can be 21 active pills and 7 placebo, or 24 active pills and 4 placebo. Shortening the hormone-free interval may decrease symptoms associated with hormone withdrawal, like mood symptoms, headache, or pelvic pain. The placebo pills are either inactive or reminder pills. Ferrous fumarate, which is iron. Levometholate, which is L-methylfolate or the active form of folate or vitamin B9. This is to raise folate levels for the purpose of reducing the risk of neural tube defects in a pregnancy conceived during use or shortly after discontinuation of the product. Monophasic combined oral contraceptives are usually preferred due to the ease of use and then also consistent hormone dosing. Another type of combined oral contraceptives are the multiphasic type. This is when hormone doses vary throughout the pack. It was introduced as a strategy to reduce hormone-related side effects and unscheduled bleeding, and then also for business-related reasons. Reasons like patents expiring and competition for market advantage. There is no data that shows that these preparations have any important clinical advantages over monophasic. Efficacy is similar across all combined oral contraceptives. There are some concerns that the changing hormone levels can exacerbate mood symptoms in some patients, like those with premenstrual syndrome and PMDD. The multiphasic formulations come as biphasic, triphasic, and quadriphasic. Biphasic may be associated with more breakthrough bleeding versus triphasic. With triphasic, doses of hormones change about every 7 days. An example of a quadriphasic formulation is Natasio, which has 26 active pills and 2 placebos. It's the first and only birth control pill approved to treat heavy menstrual bleeding. Another type of combined oral contraceptives that we have are extended cycle. This is a 91-day regimen with 84 active or combo pills and 7 days of either placebo or 10 micrograms of ethinyl estradiol only. These have a higher risk for breakthrough bleeding, unpredictable bleeding, and spotting. It's a common problem with the first 3 to 6 months of treatment, but the frequency declines over time and becomes similar to that for cyclic regimens. We also have continuous dosing, which is a 365-day regimen. So this is when you take active pills every day for a year. Withdrawal bleeding provided by the hormone-free interval is not medically necessary. You can take these pills every single day and never have a period, and this can be perfectly healthy to do. Reduction and elimination of withdrawal bleeding has been found to be helpful with endometriosis, premenstrual dysphoric disorder, hyperandrogenism. It can help with lifestyle needs and honestly, I think save money on not buying pads and tampons. It can also help with dysmenorrhea or pain during the menstrual cycle, and then also with management of menopausal symptoms in perimenopausal patients. A continuous regimen is preferred in these patients. Some extra information about combined oral contraceptives. The pills containing 50 micrograms of ethinyl estradiol are not indicated for routine use because of its increased risk of cardiovascular events compared to lower dose combined oral contraceptives. An example is Kilnor 150. The higher dose estrogen formulation is generally not used for contraception, but it's available for acute treatment of uterine bleeding. I'll also mention that Loloestrin FE contains the lowest amount of ethinyl estradiol on the market, which is 10 micrograms. It contains 26 active tablets and 2 placebo, which is actually ferrous fumarate. It's around $200 for a 30-day supply in GoodRx, and it hasn't been studied in patients with a BMI greater than 35. Half of the patients had unscheduled bleeding with the first month of use, and then 1/3 continued to have unscheduled bleeding and spotting after 1 year of usage. Alright, part 3 of my comprehensive hormonal contraceptive presentation. When starting someone on an oral contraceptive agent, it makes sense to start with the 20 micrograms of ethinyl estradiol and then increase if unscheduled bleeding becomes a problem. Some side effects of too much estrogen would be nausea, vomiting, bloating, decreased libido, and breast tenderness, and some signs of estrogen deficiency would be something like vaginal dryness or early cycle breakthrough bleeding or continuous bleeding. Some signs of too much progestin would be acne and hirsutism, which is excessive growth of male pattern hair that appears in the face, back, chest, abdomen, and thighs in women, and then also vaginal yeast infections. Some signs of progestin deficiency would be heavy menstrual bleeding or late cycle breakthrough bleeding. We classify progestins by generation, and each one has different activity on the estrogen, progesterone, and androgen receptors. For example, second-gen progestins have high androgenic activity, so they're more prone to cause acne, hirsutism, weight gain, fatigue, and depression. One example is levonorgestrel. Fourth-generation drospirenone is an aldosterone antagonist and a weak anti-androgen. Aldosterone is a mineralocorticoid that plays a role in regulating blood pressure, so it causes sodium retention and then potassium excretion. Consider monitoring potassium during the first treatment cycle, and if the patient begins another medication or has a condition that puts them at a risk for hyperkalemia or increased potassium levels. Some medications that can increase potassium are ACEs and ARBs, aldosterone antagonists, NSAIDs, triamterene, and amiloride. The structure of drospirenone is really similar to spironolactone, which is an aldosterone antagonist and anti-androgen. It's a potassium-sparing diuretic and it's sometimes used with heart failure. Drospirenone is said to have a similar potency of about 25 milligrams of spironolactone. Drospirenone is good for patients who have problem with acne, and then I'll also mention that I have had patients on both these medications, drospirenone containing and then also spironolactone. So some early side effects of combined hormonal contraceptives are nausea, breast tenderness, and headache, and they usually resolve within the first month of usage. Unscheduled bleeding is more common with the 20 micrograms of ethinyl estradiol or the 24/4 dosing regimen versus the 30 micrograms of ethinyl estradiol and the 21 7-day dosing. Extended cycle regimens also have a higher incidence of breakthrough bleeding. Again, this is the 84/7, and unscheduled bleeding is very common, especially with the first 3 months of therapy. Another side effect that can happen is amenorrhea or lack of menstruation. This is desirable in some patients. One serious side effect is stroke. The absolute risk doubles in patients using combined hormonal contraceptives. The risk is higher in patients of higher age, and then also the risk of myocardial infarction or heart attack and stroke increases with higher estrogen doses. And again, stroke risk increases in patients who smoke. I'll also mention again that the risk of thromboembolic events with combined hormonal contraceptives is lower than during pregnancy and the postpartum period. Data concerning mood is conflicted, and most studies suggest that it doesn't negatively impact mood for most patients. There was a study that showed an increase in incidence of first-time antidepressant users with patients who used combined hormonal contraceptives versus non-users. A prospective study that I found showed that a small number of patients experienced an increase or decrease in moodiness on combined hormonal contraceptives. There may be a higher incidence of mood symptoms with higher estrogenic formulations. And again, the changing hormone levels with multiphasic formulations can exacerbate some mood symptoms in some patients. One combined hormonal contraceptive patch is Xulane. This is the generic version of Ortho-Evra, which was discontinued in 2014. Another version of the generic patch is Zifemi. The patch is applied every 3 weeks, and then week 4 is patch-free. So you have to apply it to clean, dry skin on the upper outer arm, abdomen, buttocks, or back. The patch may not be effective in patients that are greater than 198 pounds, and it shouldn't be used in patients with a BMI greater than 30. If the patch falls off and does not stick back onto the skin completely, you must use a new patch. It doesn't work if you tape it either. It has to adhere to the skin for drug absorption. If the patch has been off your skin for greater than 2 days, then you need backup contraception for 7 days after you apply a new patch. A couple other things is that you cannot apply the patch to the breasts, and then also if you want to skip your hormone-free week, you can do that. You can just reapply a new patch for the 4th week and keep going. The area under the curve and the average concentration at steady state for the ethinyl estradiol in this patch is about 60% higher versus 35 micrograms in a combined oral contraceptive. Right now, it's not known whether or not this increases the VTE risk versus combined oral contraceptives. The most common side effects are breast signs and symptoms being like pain, tenderness, swelling, and then headache, and then also application site reactions as well as nausea. We can also see some abdominal pain, dysmenorrhea, irregular intermenstrual bleeding, and then mood swings. Another patch is Twirla. This is also applied every 3 weeks, and then week 4 is patch-free. It may not be as effective for BMI greater than 25 and should not be used if BMI exceeds 30. This patch is applied to the buttock, the abdomen, or the upper torso, again, not on the breasts. If the patch is off greater than 24 hours, again, backup contraception is needed for 7 days after reapplication. Twirla contains less ethinyl estradiol as well as a lower AUC versus Xulane. It's comparable to low-dose oral contraceptives. Twirla has a little bit better side effect profile versus Xulane, and it's generally well tolerated. Some side effects would be application site disorder, which includes site irritation, itching, rash, or discoloration, as well as nausea, dysmenorrhea, and weight increase. For vaginal rings, first we have NuvaRing. This is a ring that you leave in your vagina for 3 weeks and then you remove it for 1 week. You can also keep it in for 4 weeks. Studies show that it's still effective after 4 weeks and then replace it. It's refrigerated when it's in the pharmacy, but once you receive it, you can store it at room temperature for up to 4 months. After inserting it, if it feels uncomfortable, it may not be high enough. Expulsion of the ring can also happen with intercourse or bowel movements. If it's out of the vagina less than 3 hours, rinse it with cool water and then reinsert it. If it's out of the vagina greater than 3 hours and you're on week 1 or 2, reinsert it and use backup contraception for 7 days. If it's week 3, use a new ring and then also backup contraception for 7 days. The most common side effect is vaginitis, which can cause pain, irritation, itching, and discharge. Some other side effects are headache and mood disorder. FYI, this is very rare, but toxic shock syndrome has been reported in some NuvaRing users, so it's important to know that some of these patients were also using tampons. A causal relationship has not yet been established. Another vaginal ring on the market is Anovera. It was FDA approved in late 2018, and it provides contraception for 13 28-day cycles, or a year. The ring is also inserted for 3 weeks, followed by 1 week without the ring, and then reinserted for another 21 days. The side effect profile came from the clinical trials portion of the package insert. The most common side effects were headache, nausea, vomiting, vaginal candidiasis, again yeast infections, abdominal pain, dysmenorrhea, and vaginal discharge. They also saw UTIs, breast pain, tenderness, and discomfort, menorrhagia, diarrhea, and genital pruritus or itching. This ring is not refrigerated, and after removing, wash it with mild soap and warm water, rinse and pat dry with clean cloth towel or paper towel, and then store it in the case provided. You're also going to want to wash and dry it before reinsertion. The retail cash price is around $2,700. With the GutterX, it's about $575. Both with the NuvaRing and Anovera, they don't have to be removed with intercourse, but you can. With the Anovera, if the ring is out of your vagina for greater than 2 hours in one time, you need backup contraception for 7 days. Also with this is if the ring is out at different times that add up to greater than 2 hours over the first 21 days of your cycle, backup contraception is needed until it's been in the vagina for 7 days in a row. These are progestin-only contraceptive options. First, we have progestin-only pills, we have an implant, we have an injection, and then we have hormonal IUDs. Progestin-only pills suppress ovulation in about half of its users, and they also thicken cervical mucus, which decreases sperm penetration and motility to the egg. If the pill has been started greater than 5 days since menstrual bleeding started, backup contraception is needed for 2 days. Breastfeeding on progestin-only pills are not shown to harm the baby, however it does pass into breast milk. Up to 10% of pregnancies that occur in progestin-only pill users are extrauterine, aka an ectopic pregnancy. This happens when a fertilized egg implants and grows outside the main cavity of the uterus, most often in the fallopian tube, which carries eggs from the ovaries to the uterus. This can be a medical emergency. A couple signs are lower abdominal and pelvic pain and abnormal bleeding. Around 40 to 50% of patients on progestin-only pills will have cyclical withdrawal bleeding, around 40% will have irregular cycles or spotting, and around 10% will have amenorrhea. Taking the pill at the same time every day and eliminating missed doses will minimize the frequency of unscheduled bleeding. Some contraindications to progestin-only pills are history or active breast or progestin-sensitive cancer, undiagnosed or abnormal genital bleeding, liver tumors or liver disease, and pregnancy, although it won't harm the baby. Some added contraindications to SLIND are adrenal insufficiency and renal impairment due to the risk of hyperkalemia. Alright, part 4 of my comprehensive hormonal contraceptive presentation. The first progestin-only pill I'm going to talk about is norethindrone. It contains 28 active tablets. It has a 3-hour missed dose window. If taken perfectly, 1 in 200 patients will get pregnant within the first year. With typical usage, 1 in 20 patients will get pregnant. Taking it at the same time every day is incredibly important for efficacy. Another option is SLIND or drospirenone. It has 24 active tablets and 4 placebo. This one has a 24-hour missed dose window. The first over-the-counter birth control approved in the US is Opill or Norgestrel. I heard it's hitting the shelves in April sometime. It's about $19.99 per pack, $49.99 per 3-pack, and $89.99 per 6 months. It's available on Opill.com. It's a second-generation progestin, so again it has weak androgenic activity, and the active isomer is levonorgestrel. Its common side effect is irregular vaginal bleeding, spotting, and breakthrough bleeding. Side effects with greater than or equal to 5% incidence are nausea, breast tenderness, discomfort, headaches, abdominal pain, cramping, bloating, fatigue, dizziness, vaginal discharge, nervousness, dysmenorrhea, backache, increased appetite, weight gain, and acne. Opill also has a 3-hour missed dose window. You have to take it at the same time every day. This has to do with its rapid distribution and elimination and lower steady-state progestin levels and shorter elimination half-life versus combined hormonal contraceptives. If you forget to take it at your normal time, take it as soon as you remember and go back to the usual time that you take the pill. This means that you can sometimes take 2 tablets in one day. It's recommended to use a condom or another barrier method during intercourse for the next 48 hours after restarting. Efficacy with perfect usage is around 98%, which is similar to other oral contraceptive agents. This means that 2 in 100 female patients will get pregnant with 1 year of usage. You need backup contraception for 48 hours after you first start the medication, and then also if you vomit within 4 hours after taking the dose. The American College of Obstetricians and Gynecologists, aka ACOG, has long supported the over-the-counter access to oral contraceptives. Progestin-only pills don't carry a lot of the risks that estrogenic contraceptives have. Moving this over the counter will remove a lot of barriers for a lot of patients. Another progestin-only option is the Nexplanon implant. This is the most effective contraceptive method with a pregnancy rate of 0.05%. It lasts 3 years, and an appointment is required for insertion. Sometimes they'll inject lidocaine as a numbing agent before the incision. If it's inserted greater than 5 days since menstrual bleeding, you need backup contraception for the next 7 days. For return of fertility, pregnancies were observed as early as 7 to 14 days after removal. Important to note that there are post-marketing reports of VTE, DVT, PE, MI, and stroke, so it's contraindicated with current or history of thrombosis or thromboembolic disorders. It's also not to be used less than 21 days postpartum due to the clot risk. Irregular bleeding is the most common reason patients stop treatment. Some common side effects were headache, vaginitis, weight increase, acne, breast and abdominal pain, and then also pharyngitis. Another progestin-only option is the injection, or the depomedroxyprogesterone acetate, or Depo-Provera. It comes as an intramuscular injection that can be injected into the glute or the delt, and then also as a subcutaneous injection that can be injected into the thigh or the upper abdomen. It's given every 3 months or every 12 to 13 weeks. According to Planned Parenthood, you can give the injection as early as 10 weeks. According to the CDC, there's no really time frame with that. They just say that you can give the injection early when necessary. You can give it a few weeks late, but if it's greater than 15 weeks between injections, you need backup contraception. Return of fertility is kind of long. On average, it takes about 10 months. If the Depo-Provera started greater than 7 days since menstrual bleeding, you need backup contraception for 7 days. Indiana Code 2526.13.2 defines a lot of terminology within the law, but it also defines the practice of pharmacy, which includes the administration of drugs. And administering means the direct application of a drug to the body of a person by injection, inhalation, ingestion, or any other means. So pharmacists can administer the Depo-Provera to patients. This does save money and time for the patient, so they don't have to make another appointment for the injection, but it does pose as a liability, so it's going to depend on the pharmacist and the store policy. With continued usage, the most common bleeding pattern is no bleeding. Absence of all bleeding and spotting after 1 and 5 years is 50 and 80% respectively. Unpredictable bleeding and spotting is common within the earlier months. Some other common side effects are headache, abdominal pain and discomfort, increased weight, nervousness, dizziness, and decrease in libido. Some studies have showed that the weight gain with the Depo-Provera is more prominent than with oral contraceptives. One observational study specifically in adolescents showed that over 6 months, the Depo-Provera had a 10.3% increase in total body fat versus a decrease of 0.7% with non-hormonal methods. Another study showed that patients gained on average 11.2 pounds over 36 months versus combined oral contraceptives. The package insert showed after 1 year, patients gained on average 5.4 pounds. They gained 8.1 after 2 years, 13.8 after 4 years, and 16.5 pounds after 6 years on average. The Depo-Provera has a black box warning of bone mineral density loss and limits its usage to 2 years unless other contraceptive methods are considered inadequate. This bone loss may not be completely reversible, and then bone loss is greater with increased duration of usage. According to ACOG, observational studies suggest a possible increased risk of fracture in DMPA users. However, the results must be interpreted with caution because of inherent limitations in study design. After 5 years of usage, we see a spine and hip BMD mean decrease of about 5 to 6%. In the 2 years post-therapy period, we see a partial recovery of BMD towards baseline values. According to a few different clinical practice guidelines, advantages of DMPA use as a contraceptive generally outweigh concerns regarding skeletal harm. We see the greatest BMD loss during the first 1 to 2 years of usage, but after that it appears to plateau. Risks and benefits need to be weighed when considering whether or not to continue usage past 2 years. Ultimately, this is a shared decision with the provider. Another progestin-only option are the hormonal levonorgestrel IUDs. We have Mirena and Liletta, which last 8 years, Kylena that lasts 5 years, and Skyla that lasts 3 years. If inserted greater than 7 days since menstrual bleeding started, backup contraception is required for the next 7 days. Fertility can return immediately after IUD removal. Levonorgestrel plasma concentrations are highest 7 days post-insertion and then gradually declines over time. This level is half that of progestin implants and much less than progestin-only pills. Lower plasma concentrations equals less systemic side effects. Levonorgestrel IUDs have minimal impact on ovulation. 45% of cycles are ovulatory using the 52 milligrams versus 88 to 97% for lower dose IUDs. Intrauterine levonorgestrel concentrations are much higher than systemic concentrations. Activity is primarily local. Uterine levonorgestrel concentration is much higher in levonorgestrel IUD users compared to levonorgestrel containing oral contraceptive users. USMEC Category 4 contraindications to IUDs. Again, unacceptable health risk, method should not be used. We have current pelvic inflammatory disease or pelvic TB, current purulent cervicitis, chlamydial or gonococcal infection. Breast cancer is a contraindication for the levonorgestrel IUD only. Endometrial cancer is a contraindication. There's a concern about an increased risk of infection, perforation, and bleeding at insertion. I will mention that those at an increased risk of developing endometrial hyperplasia can benefit from the local progestin effects of the levonorgestrel IUD. We have cervical cancer, unexplained vaginal bleeding, distorted uterine cavity, immediate post-septic abortion, postpartum sepsis, and then also pregnancy, although there's no evidence that IUDs disrupt an implanted pregnancy, so it's not an abortifacient. Bleeding and spotting between menstrual periods is common, especially during the first 3 to 6 months. By 6 months of usage, about 62% of patients report lighter bleeding, and then after 1 year of usage, 2/10 of patients stop having periods. Mirena and Kylena have higher doses of levonorgestrel, 52 milligrams, and they're associated with less breakthrough bleeding. The risk of expulsion is about 2 to 10% for all IUD users, and then it can be up to 20 to 35% with postpartum and immediate postplacental insertion. Malposition can occur in up to 10% of patients. Embedment can happen sometimes where the IUD becomes attached to the uterine wall, and patients might need surgery to have it removed, and it can also advance to a perforation. Malposition is more likely to cause symptoms of pain and abnormal bleeding, and may also decrease efficacy. Some more serious side effects include perforation, which can happen in 1.4 per 1,000 levonorgestrel IUD insertion. Infection is more common within the first 20 days after insertion, and the cumulative risk is about 0.1%. The pregnancy rate after about a year of usage is 0.5 to 0.8%. Patients less than 25 years old are at a slightly higher risk of failure. If pregnancy occurs, levonorgestrel IUD users are at an increased risk for an ectopic pregnancy, which ranges from 27 to 50%. Alright, this is part 5 of my comprehensive hormonal contraceptive PowerPoint. Insertion with IUDs can be painful. Some risk factors that increase pain scores are nulliparity, which means the patient has not given birth yet, postmenopausal status, history of dysmenorrhea, and then also anxiety. Skyla and Kylena may be easier and less painful versus Mirena because of smaller insertion tube diameter. Patients report no pain or mild pain more often with Skyla and Kylena versus Mirena, and that's 72.3% versus 57.9%. Providers may choose to use NSAIDs, a paracervical block, anesthetics, and/or opioids in certain patients. Sedation may be necessary for some patients, for example those with a history of trauma, developmental delay, or significant anxiety. Scarring from prior obstetric or gynecologic procedures may make access to the cervix impossible without improved patient relaxation and positioning. Providers sometimes use nitrous oxide or benzodiazepines in these patients. The American College of Obstetricians and Gynecologists do not recommend routine use of misoprostol before IUD insertion because that has not been shown to reduce pain or enhance ease of insertion, and it has been shown to increase cramping and nausea in patients. Misoprostol may benefit those whom IUD insertions are known to be difficult or has failed, patients who are nulparous or have only had cesarean deliveries. This can be dosed at 400 micrograms buccally at least 2 hours before the procedure. There are a few different types of emergency contraceptives. First, we have Plan B or levonorgestrel. This is available over the counter, and it's less effective in patients greater than 165 pounds or with a BMI greater than 25. It has to be taken within 72 hours after intercourse. 6 studies of 8,000 plus patients estimated pregnancy prevention rates to be about 60 to 94%. One meta-analysis showed that pregnancy rates with levonorgestrel was 2.2% versus 1.4% with ulipristal or ELA. ELA is a progestin receptor modulator. It inhibits follicular rupture even after luteinizing hormone starts to increase. This is a prescription-only emergency contraceptive, and it's less effective if the patient is greater than 195 pounds or greater than a BMI of 30. It has to be taken within 5 days after intercourse, and it has higher efficacy within 72 hours after intercourse. It's recommended for the patient to get a pregnancy test if the patient does not have a period within 3 weeks after taking the emergency contraceptive. It's important to note that emergency contraceptives are not birth control and should not be routinely used as such. I'll also mention that you can buy generic Plan B on Amazon for about $7. Another emergency contraceptive is the copper IUD or Paragard. This prevents fertilization through inhibition of sperm migration and viability. This is also a non-hormonal contraceptive. This lasts up to 12 years, and some studies show that it lasts a little longer. Some side effects are heavy bleeding and dysmenorrhea. Around 71% of patients experience increased bleeding, and around 63% of patients experience cramping at 3 months after insertion. The copper IUD has shown to increase menstrual blood loss by about 50% over pre-insertion levels. It can be used as an emergency contraceptive if used within 5 days. It is the most effective emergency contraceptive with a failure rate of about 0.1%. No backup contraception is needed after insertion. Also mentioned, of course, the copper IUD does not stop periods, and then it also irritates the endometrial lining and causes inflammation. For drug interactions, first we have CYP3A4 inducers. These don't usually cause an issue with IUDs or Depo-Provera. Some examples are rifampin, rifabutin, phenytoin, phenobarbital, primidone, carbamazepine, and St. John's wort. Some minor inducers are topiramate and oxcarbamazepine. These drugs induce the metabolism and decrease the concentrations of 3A4 substrates like combined hormonal contraceptives and increase the risk for contraceptive failure. It's disputed whether or not antibiotics actually interact with hormonal contraceptives. The US MEC classifies it as a category 1, which means no restriction. It's been hypothesized that antibiotics decrease intrahepatic cycling, but they have not been proven to affect the pharmacokinetics of ethinyl estradiol. There is an interaction with lamictal. Combined hormonal contraceptives, specifically estrogens, increase lamictal's clearance via UGT induction, resulting in a decreased plasma concentration by 45 to 60%. Monophasic contraceptives may be recommended over cyclic contraceptives to avoid fluctuating levels, but caution with seizure disorder due to treatment failure. I'll also mention that some antiretroviral therapies interact with birth control, specifically the HIV protease inhibitor fosamprenavir. This is more of an issue with non-IUDs. I'll lastly mention that the antifungal griseofulvin has been associated with contraceptive failure. This is in case reports, but data is limited. Alright, transgender hormonal replacement therapy and contraception. HRT is not sufficient as a contraceptive. Testosterone may decrease fertility, but does not eliminate the risk of pregnancy. Patients are still at risk of getting pregnant despite a lack of menstruation. In a study of 41 transgender men who had been pregnant and given birth, a third of those pregnancies were unintended. Contraception use prior to pregnancy was lower in patients who used testosterone compared to those who did not. There is a lack of research on pregnancy and fertility in transgender patients, and consequently contraceptive guidelines for this patient population. For trans men and trans masculine patients, some may not prefer to use combined hormonal contraceptives due to concerns about estrogen and potential for female traits. Progestin only is a good option for some patients. They have a potential for masculinizing effects, and then also the injectable, implant, and IUDs are more convenient and have higher rates of amenorrhea. Standard testosterone therapy alone is usually sufficient to suppress menstruation after around 3 to 6 months. Some patients may want to use Provera at high doses to offer short-term arrest of bleeding, while serum testosterone reaches optimum range and stabilizes. Another option may be surgery, so a tubal ligation or a hysterectomy. Trans women and trans feminine patients, of course, options are more limited. Some options are condoms, an orchiectomy, which is the removal of the testes, and a vasectomy. I have a lot of sources, but I'll post them so you can go back to the in-text citations if you're interested. 8 through 14, 15 through 21, 22 through 28, 29 through 35, 36 through 42, 43 through 49, 50 through 57, 58 through 64, 65 through 71, 72 through 78, and then 79.